Hello everyone, my name is Sanjay Sharma. I'm Professor of Cardiology at St George's University of London. I'll be speaking to you about exercise in the heart, the good, the bad, and the ugly. The objectives of my talk are as follows. I'll discuss the cardiovascular benefits of exercise, provide a critical appraisal of the dose-benefit relationship between exercise and cardiovascular health, examine the potentially detrimental effects of exercise, and finish by discussing the risk of sudden cardiac death in sport. Let's start with the good. The benefits of exercise on the cardiovascular system are well established. People who exercise regularly are more likely to be of normal weight, have a better blood pressure and lipid profile, and less likely to have diabetes mellitus. And by curbing all of these risk factors for atherosclerosis, people who exercise regularly reduce their risk of a myocardial infarction when they reach their 60s and 70s by around 50% and live 3 to 5 years longer than people who don't do any exercise at all. Here is the first study by Morris et al. In the 50s, where they examined differences in cardiovascular disease amongst busmen and postal workers, where they compared busmen that were going up and down the stairs collecting fares versus bus drivers, and postal clerks who were sedentary versus postmen who were delivering letters. And they found that the active members of these cohorts were 50% less likely to have an adverse cardiac event versus the sedentary individuals. Around 60 years later, Tănăsescu reproduced this. He examined nearly 45,000 professional males and followed them up for a total of nearly 480,000 person years. And compared to individuals that were inactive, that was our reference, people who ran more than 1 hour a week reduced their risk of a cardiovascular event by 42%. We know that apart from the normal population benefiting from exercise, people who actually have cardiovascular disease also benefit. Here is a large study from Korea where they looked at 131,500 people with cardiovascular disease and 310 without cardiovascular disease. These individuals filled in a health questionnaire about how much leisure activity they did, and they were followed up for 5.9 years. Here you see the relationship between the incidence of mortality in those with cardiovascular disease in the red and those without cardiovascular disease in the blue. And you'll see that there's an inverse relationship between the amount of exercise being performed and the incidence of mortality, both in people with cardiovascular disease and those without. But what you will notice is that the benefit is much greater in people with cardiovascular disease. Indeed, for every 500 minutes per week of exercise performed, there was a 14% reduction and a 7% risk reduction, respectively, in those in the primary prevention group, i.e. those that had cardiovascular disease versus those that didn't. Here, you will see again the relative risk of mortality in people with cardiovascular disease in the red and people without cardiovascular diseases in the blue. You will notice that people without cardiovascular diseases benefit most from going sedentary to 500 minutes, whereas those with cardiovascular disease continue to benefit beyond 1,000 minutes. So what we should be telling our patients and individuals is that if they've got cardiovascular disease, they are more likely to benefit from exercise. It's also never too late to start exercising. Here is another study looking at changes in exercise frequency and cardiovascular outcome in the older population. This is another Korean study that enrolled over 1 million individuals with a mean age of nearly 67 years old, and many had underlying cardiovascular risk factors. They looked at change in the frequency of moderate to vigorous physical activity in older individuals, and they found that during this follow-up period of 3 years, those people that went from physically active to sedentary increased their risk of cardiovascular disease by 27%, whereas those people that went from sedentary to active reduced their risk of cardiovascular disease by 11%. We also know that people who exercise reduce their risk of atrial fibrillation and ventricular arrhythmias. Here's a large study from the UK Biobank that suggests that exercising regularly, that's moderate exercise for 30 minutes, 5 times per week, reduces your risk of atrial fibrillation and ventricular arrhythmias. We know that atrial fibrillation is a disorder, an arrhythmia that is associated with increased risk of stroke, heart failure, and all-cause mortality. But this study here from the Hunt investigators showed that those individuals with atrial fibrillation that exercise and are fit have a lower event rate than people who are relatively sedentary. If we look at the benefits of formal exercise training on the risk of on the risk factors for atherosclerotic coronary artery disease, we will find that the reduction in risk factors is relatively modest. For example, the systolic blood pressure drops by 5, the diastolic blood pressure drops by 3, the total cholesterol only drops by 5%, LDL cholesterol by 2%, and the triglycerides by 15%. Body mass index by 1.5%. However, one thing that does happen is that the peak oxygen consumption, which is a marker of fitness, increases significantly. And what this tells us is that exercise has greater benefits on lifespan that go beyond curbing risk factors for atherosclerotic coronary artery disease. So apart from curbing these risk factors, such as reducing body mass index, reducing the risk of diabetes and hypercholesterolemia, exercise increases heart size, cardiac filling in diastole and stroke volume. It reduces aortic stiffness and systemic vascular resistance. It increases left ventricular compliance and improves atherosclerotic plaque stability. Exercise also increases capillary conductance, endothelial function, reduces oxidative stress and thrombogenicity. It has autonomic effects and reduces heart rate, increases ion channel expression, improves electrical stability, and it also increases myokine release, which is an anti-inflammatory effect and reduces C-reactive protein levels. And it's through all these mechanisms that exercise has all its pleiotropic benefits. In fact, if we look at the relationship between cardiovascular fitness, cardiovascular disease, and all-cause mortality, you see that there is an inverse relationship with increasing activity, with every 30 to 20%, with every increase in MET of exercise, there's a 13 to 20% reduction in cardiovascular disease and all-cause mortality, and that happens irrespective of age, sex, ethnicity, the presence of comorbidities, and even affects the fit and ostensibly healthy individuals. Here's a study on over 4,000 middle-aged individuals with a mean age of 43 years old who had a baseline cardiopulmonary exercise stress test to estimate their fitness levels. They were followed up for 24 years, during which around 18% died. And you see here, whether we look at men at the top or women at the bottom, there was an inverse relationship between the amount of exercise being performed and the risk of all-cause mortality. In fact, for every 1 MET increase in fitness, there was a 12% reduction in all-cause mortality, a 16% reduction in cardiovascular mortality, and a 14% reduction in cancer mortality. There was another study, a much longer study in middle-aged men, nearly 5,000 of these people who were aged 48.8 years old. And these individuals were divided according to their fitness levels, where 5% had a below normal fitness level, 45% had a low normal level, 45% had a high normal level, and 5% had an above normal fitness level. They were followed up for a long time, 46 years, during which, of course, most of these people died because they were middle-aged before they started. But this is the comparison amongst individuals. This is cumulative incidence of all-cause mortality amongst individuals who had a below normal fitness level at the top, and in the blue, people who had an above normal fitness level. So people who had an above normal fitness level increased their lifespan by nearly 5 years compared to people who had a below normal fitness level. So what I'm trying to tell you all is that exercise is probably the best therapy that has ever been invented, and I don't think there is anything that's going to surpass its benefits. Apart from having cardiovascular benefits, exercise reduces the risk of cancer, osteoporosis, dementia, improves stamina, curbs depression, and improves anxiety. The current guidelines suggest that everybody should be performing 30 minutes of moderate intensive physical activity at least 5 days per week, or 25 minutes of vigorous activity 3 days per week. And these are the ESC recommendations suggesting this. And you will see here at recommendation 2, and rightly so, that they say that you should be doing 150 minutes a week at a minimum, and you should be trying to do at least 300 minutes per week. Here is data, a meta-analysis of 174 studies looking at the risk of breast cancer, chronic cancer, diabetes mellitus, ischemic heart disease, and ischemic stroke, with a large follow-up of almost 150 million person years, looking at the impact of exercise on the reduction of all of these morbidities. And we find here that the greatest benefit occurs at a exercise of 3,000 minutes per week, which is around 4 to 5 times the current recommendations. So everybody should be doing at least 30 minutes of exercise, but should be trying to really do a minimum of 2 times more, maybe 4 to 5 times more. Of course, we're talking about sports cardiology, and our athletes do far more. They do 10 to 15 times the current recommendations for exercise. These people are role models for all of us, and as a result of them, there are so many millions of individuals that are participating in mass endurance events. But what does exercise actually do, intensive exercise, to the heart? What it does is it causes changes in the cardiovascular structure and function, which improves cardiac output during exercise, and it's associated with peripheral adaptations to improve the uptake of oxygen by the skeletal muscle by increasing the capillary conductance, that's the number of capillaries surrounding the heart, surrounding the skeletal muscle, and increasing the amount of mitochondria and the enzymes responsible for oxidative phosphorylation within the skeletal muscle. Within the heart, there are a plethora of electrical, structural, and functional changes. The athlete's heart shows bradycardia, increase in cardiac chamber size, enhanced filling in diastole, augmentation of stroke volume during intense exercise, and the net result is an increase in peak oxygen consumption. This is typical of an athlete's heart. Here you see sinus bradycardia with large QRS complexes. And as far as structural remodeling goes, athletes normally have a 10 to 20% increase in left ventricular wall thickness and a 10% increase in left and right ventricular cavity size. The magnitude with which these manifestations of athlete's heart are manifest in an athlete are governed by several demographic factors such as age, sex, ethnicity, and the type of sport. And some athletes have very large dimensions. Here is a slide on over 1,000 Italian Olympiads looking at the distribution of left ventricular cavity dimensions, where the blue bars represent the male athletes and the red bars represent the female athletes. And the one thing that you'll notice is that males have larger dimensions than females, but more importantly, around half of the athletes cavity size of more than 54 millimeters, which is the upper limit of normal for the general population. And around 14% have a left ventricular cavity size of more than 60 millimeters, which really is an enlarged ventricle that can sometimes simulate dilated cardiomyopathy. When these individuals detrain, these large dimensions usually go back to normal. Here's a study of 44 Italian Olympiads, athletes who were rowers, who had a wall thickness of more than 13 and a big left ventricular cavity size. When they detrained for 4 years, most things went back to normal. So it's believed that athletes who get large dimensions usually may revert back to normal when they detrain. And as a result of this, the athlete's heart is considered a benign physiological adaptation to exercise. But what about the bad? There are now emerging studies that show that there's a reverse J-shaped relationship between physical activity and mortality. Several studies have shown that too much of a good thing can be a bad thing. Here's a study from Denmark where they compared 1,098 joggers versus 3,950 healthy non-joggers aged between 20 and 86, and they followed them up for 12 years. They compared mortality in sedentary non-joggers, light joggers, moderate joggers, and strenuous joggers, and then they corrected it for age, sex, and cardiovascular risk factors. You will see here that compared to people who didn't jog, those people that did light jogging and moderate jogging benefited, reduced their risk of all-cause mortality. But strenuous joggers had no advantage over people who were sedentary. And when corrected for age, sex, and comorbidities, this study suggested that people who were jogging strenuously, i.e. exercising around 4 to 6 times more than the current recommendations, actually had an increased mortality. And this study received a lot of publicity in the press, suggesting that too much exercise could be detrimental. But I'd like to point out some important things. That whereas the light jogger group and the moderate jogger group consisted of a very large number of individuals, the number of people participating in strenuous exercise was very small. So we only had 36 individuals in this age group. And if we look at the deaths, there were only 2 deaths. So this study showed that jogging 1.2 to 4 hours over 2 to 3 times per week at a slow to moderate pace was associated with the best results. But I'm not sure whether they convinced us that doing too much exercise was detrimental, because the number of deaths was very, very small and the confidence limits were very wide indeed. Here's a much bigger study, 15-year observational study looking at 55,000 individuals with a mean age of 44 years old, where these people jogged. And this study showed that runners had a 30% all-cause reduction in mortality and a 45% reduction in cardiovascular events. In these charts, you will see the hazard ratio of cardiovascular morbidity or mortality in relation to running distance, running frequency, and running speed. And you see that there's a sort of a U-shaped curve throughout these charts. And what these investigators showed, that for the best results, you should run between 6 and 12 miles per week, divided over 3 periods at a pace of about 6 to 7 miles. In their highest segment of exercise, their highest quintile, they showed that compared with moderate exercise, those people that exercised much more intensively, i.e. ran more than 20 miles a week at a pace of more than 8 miles an hour, did not benefit any more than people who didn't do much exercise. But I should emphasize that they were not able to show a threshold for increased mortality. So all they showed was that you don't have to do a lot to benefit, but I am not convinced that they showed that too much exercise was detrimental. All they showed was there was a reduction in the improvement that you would experience with increasing amount of exercise. Now, over time, some of you may have read that people who exercise have high troponin concentrations in their bloodstream. In fact, around 50% of people who finish a marathon have high serum cardiac troponin levels, which are usually a marker of myocyte damage. Studies have also shown that people who have finished a race like the marathon have slightly reduced left and right ventricular function for a few days afterwards that normalizes. This has led people to speculate that these release in biomarkers of myocardial damage or myocardial stress may actually represent myocardial inflammation and may go on to repair with myocardial fibrosis, resulting in adverse cardiac remodeling, cardiac dysfunction, and a predisposition to cardiac arrhythmias. Animal studies would certainly support that. Here is a study on rats exercising for 60 minutes every day for 16 weeks. That's almost like running 10 Ks every single day for several weeks. For a rat, that for a human being, that would be for several years. When they sacrificed these rats, what they found is that the rats had enlarged atria, right and left ventricular hypertrophy, and evidence of fibrosis within their atria and fibrosis within their right ventricles. They also had impaired myocardial relaxation, and they were more prone to ventricular arrhythmias. We certainly know of the past decade now that endurance athletes, certainly male athletes, have a higher prevalence of atrial fibrillation compared to age-matched individuals who do not exercise excessively. Here's a meta-analysis which showed that the risk of atrial fibrillation is fivefold greater amongst middle-aged male endurance athletes. So to develop atrial fibrillation, you have to be male, aged between 40 to 60 years old, engaging usually in endurance sport, having exercised for a lifetime of 1,500 hours, and having a tall stature. All these are supposed to be risk factors for atrial fibrillation with endurance exercise. So what are the mechanisms? Well, we know certainly that exercise is associated with pressure and volume overload of the heart, which does result in atrial stretch. It can cause myocyte hypertrophy and atrial dilatation. And there is now emerging evidence that it may also cause inflammation within the atria and atrial fibrosis, which may all be triggers for atrial fibrillation in the future. In this large cross-country skiing study, one thing that the investigators showed is that arrhythmias such as atrial fibrillation correlated with the number of races completed and faster finishing times. So the more that individuals did and the more strenuous effort that they made them more prone to atrial fibrillation. We also know, certainly from studies in Belgium particularly, that endurance exercise may cause right ventricular damage. There have been studies that have shown that cyclists, sometimes presenting to electrophysiological departments with ventricular arrhythmias, have evidence of right ventricular enlargement and right ventricular dysfunction. And genetic studies in these individuals have shown a lower level of desmosomal mutations compared to individuals with ARVC, suggesting that exercise itself may result in a form of arrhythmogenic cardiomyopathy. This is a seminal study from Hein Heidbuchel, who reported 46 of these endurance athletes, mainly cyclists, who presented to the department with symptoms and complex ventricular arrhythmias. They had very abnormal ECGs at presentation and often had evidence of ventricular tachycardia coming from the right ventricle, and several fulfilled criteria for arrhythmogenic right ventricular cardiomyopathy. During follow-up, 9 died and 9 ended up getting an ICD. Here is a study of genetics looking really for desmosomal mutations by André Legerche. He examined 47 of these individuals with genetic testing, and he found that compared with your usual ARVC yield of genetic mutations for desmosomal mutations, the athletes who fulfilled criteria for ARVC, only 12.8% actually had mutations capable of causing the disorder. And what he found was that you were more likely or less likely to have a mutation the more exercise you did, suggesting that exercise may actually cause adverse remodeling of the right ventricle that could result in ARVC. They did another study, this is Legerche et al., where they actually exercised 40 healthy endurance athletes immediately before and after 7 days of an ultra endurance race. They measured troponin levels and did echocardiographic studies in these individuals. And what they found at the end of exercise was that the left ventricle looked a little bit shrunk, whereas the right ventricle had ballooned out and was not contracting as well as the left ventricle. And the magnitude of these changes correlated with the magnitude of troponin levels. The higher the troponin levels, the larger and worse dysfunction of the right ventricle. These changes improved over a week. But what they postulated was that endurance exercise may cause acute reversible right ventricular injury that will repair in many people, but in some people who are genetically predisposed, this environmental stress of exercise may result in progressive detrimental remodeling or damaging effects of the right ventricle that could eventually result in an ARVC phenotype. We have learned over the last 5 or 6 years, certainly, that individuals with ARVC who exercise are more prone to accelerate their phenotype versus people who exercise only moderately. This was initially shown in knockout mice with desmosomal mutations and has since been shown very convincingly in human probands with genetic mutations capable of causing ARVC, where they've shown that endurance athletes with these mutations are more likely to develop this phenotype prematurely, presenting with fatal arrhythmias and heart failure. Here's a study of 110 such individuals, of which 34% were endurance athletes and exercised vigorously for more than 4 hours a week. Here's the relationship between the amount of exercise and right ventricular ejection fraction. And you will see that the more exercise that was being performed over this period of surveillance, the worse the right ventricular ejection fraction. And that's led many of us to believe that certainly if you've got a mutation capable of causing ARVC, then an individual may go on to develop ARVC even if they don't exercise very much. But some people may have genetic modifiers where environmental stresses such as exercise may actually promote the ARVC phenotype. So there's an interplay between exercise and genes that may actually result in ARVC. And in some people, too much exercise, particularly those that are prone to right ventricular dysfunction, may be a bad thing. There's also been data to show that people who engage in marathons have a higher coronary artery calcification and have a higher prevalence of myocardial fibrosis. Here's a study from our group that examined individuals that had exercised for 31 years, participated in a median of 13 marathons, and we looked at 54 male controls versus 54 athletes with a mean age of around 55 years old. And we could not, and these guys all had a low Framingham risk score. So they were at low risk of atherosclerotic coronary artery disease. We couldn't find any difference between these athletes and controls as far as the CAC score was concerned. Both groups had a high prevalence of low CAC or zero CAC. But we found there was a trend towards male athletes having a higher prevalence of a coronary artery calcium score of more than 100 Agatston units. In fact, almost 1 in 5 male athletes who would normally be at low risk of atherosclerosis had a coronary artery calcium score of more than 100. When we examined things in more detail, we found that 11.5% of our veteran male athletes had a coronary artery calcium score of more than 300, this is the red bars, versus none of our controls. And when we looked at the coronary arteries in more detail, where the controls are in the blue bars and the athletes are in the red bars, we found that the athletes had a twofold greater number of atherosclerotic coronary plaques compared to our controls. And 7.5% of our athletes had a luminal stenosis of more than 50% compared to none of our controls. And these certainly findings looked a little bit worrying until we examined the morphology of the plaques. So here we've got a bar chart where we look at our athletes and our male controls, examining the morphology of the plaques, where the dark blue shade represents calcified plaque and the yellow and light green represents mixed morphology plaque or soft morphology plaque. We found that our male athletes, although they had more plaques, they were much more likely to have a calcified and stable plaques that are less likely to rupture and cause myocardial infarction compared to our controls. So it seems that athletes actually do exercise and do cause some form of trauma to the arteries, but the repair mechanisms appear to be different and seem to result in calcified plaques. At around the same time, the Dutch group published a similar study looking at the relationship between exercise volume, coronary artery calcification, and coronary plaques in almost 300 male athletes, where they divided them into those people that did less than 1,000 minutes of exercise per week, those that did a moderate amount of exercise, that's between 1,000 and 2,000 minutes per week, and those that did a lot of exercise, more than 2,000 minutes per week. Here's the relationship between those with a coronary artery calcium score of 0 and the amount of exercise. And you'll see that compared to people who did less than 1,000 METs, those that did more than 2,000 METs were more likely to have a coronary artery calcium score of more than 0. Here's the same relationship between the prevalence of plaques and the amount of exercise. And you see the same thing. Those people that did the most exercise were more likely to have more plaques. So the higher the activity, the higher the prevalence of coronary artery calcification, and the higher the prevalence of coronary plaques. There are multiple mechanisms for this. Of course, repeated mechanical stress may result in bending and flexing of the coronary arteries, which then repairs with calcification. However, it's also possible that some of these males had confounding risk factors for atherosclerosis, or may have changed their lifestyle because they may have had previous risk factors such as hypertension, bad diet, and smoking, and decided to change things to help themselves. And that may be one of the reasons why we saw more calcium. Or it could be that exercise per se causes acute inflammation, certainly, and the repair mechanisms behind that acute inflammation result in coronary artery calcification. But more work is required to assess the significance of this coronary artery calcification. There are some studies that have emerged looking at the relationship between fitness, coronary calcification, and cardiac events. Here's a large study of over 8,000 men without cardiovascular disease who underwent cardiovascular fitness tests and a coronary artery calcium score, and were followed up for 8.4 years looking for hard events such as deaths, myocardial infarction, and stroke in people in 4 different categories, i.e. coronary artery calcium score of 0, coronary artery calcium score of between 1 and 199, coronary artery calcium score of between 100 and 399, and coronary artery calcium score of more than 400. And with increasing coronary artery calcium scores, the hard events presented per 1,000 person years did increase from 0.9 in CAC of 0 to 5.9 in CAC of more than 400. So what this study did show is that the higher your CAC, the more likely that you are at risk of an adverse cardiovascular event. But what about the relationship with exercise? Here you've got the relationship that examines the incidence of cardiovascular events compared to fitness in relation to the coronary artery calcium score, where the coronary artery calcium score of 0 is the black line here, and a coronary artery calcium score of red is a coronary artery calcium, in red is a coronary artery calcium score of more than 400. And you found that compared to people that did very little exercise, that's 5 METs of fitness, those that were much fitter had a much lower prevalence of an adverse cardiac event. So what this study shows is that if you've got coronary artery calcification and if you are fit, you significantly reduce your risk of an adverse cardiovascular event. Indeed, the risk of hard cardiovascular events decreased by 14% for each MET increase across all coronary artery calcium scores when adjusted for risk factors. Another more recent study, just over a year ago, looked at the association of all-cause and cardiovascular mortality with high levels of physical activity and concurrent coronary artery calcification. Large study, look at this, almost 22,000 men without cardiovascular disease in their middle-aged who reported their exercise volume and had coronary artery calcium scores. The exercise dose was quantified into low and high, where low was less than 1,500 METs and high was more than 3,000 MET minutes. Coronary artery calcium scores, around 5,000 had at least 100 Agatston units, and around 16,000 had less than 100 Agatston units. Here's the relationship between the relative risk of prevalent coronary artery calcium of more than 100 in physical activity categories. And you'll see that there is certainly people who exercise more definitely had more coronary calcium than people who exercise less. And that is consistent with previous studies. During a mean follow-up of 10.4 years, there were 759 all-cause deaths, 40 in the high exercise group, and 50 cardiovascular deaths, of which 10 were in the high exercise groups. Men exercising for more than 3,000 minutes with a coronary artery calcium score of 100 Agatston units did not have an increased risk of mortality compared with men exercising less than 1,500 minutes with a coronary artery calcium score of more than 100. So although too much exercise or excessive exercise did cause a high coronary artery calcium score, they did not seem to be a higher adverse cardiac event in those who continue to exercise aggressively. I would now like to turn my attention to myocardial fibrosis. There are fewer studies examining myocardial fibrosis in athletes, but this is probably the most eminent one, where there is an assessment of myocardial fibrosis in individuals who participated in triathletes. These are 83 triathletes who were aged around 43 years old, of which many were male and many trained more than 10 hours per week. They were compared with 36 controls, and all had MRI scans. In this study, 9 males who participated in triathlons, that's 17%, had evidence of myocardial fibrosis. All had a non-ischemic pattern, predominantly in the infralateral distribution, with a subepicardial involvement. And what they found is that you were more likely to get fibrosis if you had a higher blood pressure response to exercise and if you had a greater left ventricular mass index. Those people that had the highest mileage had the most, were more likely to have late gadolinium enhancement. Indeed, cycling distances of around 1,900 kilometers had a high sensitivity and specificity for predicting late gadolinium enhancement. Again, this was not a prospective study as such, so we do not know what the mechanism and significance of this myocardial fibrosis is, but our own experience at St. George's suggests that subepicardial fibrosis and mid-wall fibrosis in athletes does not appear to have an adverse prognosis, although subendocardial fibrosis, representing ischemic damage, is associated with a higher prevalence of ventricular arrhythmias. Let's finish quickly with the ugly. I'm pleased to say that the ugly side of exercise is uncommon, and that is sudden death in sport. Sudden death is uncommon and affects 1 in 50,000 athletes. Here is the largest study of almost 19,000 sudden cardiac deaths, of which around 1,050 were probably cardiac in origin. The average age of deaths was 18 years old, of which 65% were under 17, and you'll see that 89% were men. 82% of deaths occurred during sport. A significant proportion occurred in Black athletes, and athletes that participated in sport which were of a dynamic stop nature, such as football and basketball, were at the greatest risk. I should emphasize again that sudden death in sport is rare and affects 1 in 50,000 individuals. If we look at sudden death in sport amongst young individuals under 35, then deaths are due to a spectrum of cardiovascular diseases, including the cardiomyopathies, the ion channel diseases, or congenital coronary artery anomalies. Indeed, most deaths are due to inherited or congenital abnormalities of the heart. And if we examine the literature worldwide, then the cardiomyopathies are the leading cause, although there is emerging evidence that ion channel diseases may be even more important. And this suggests that exercise is a trigger for sudden cardiac death in those people who harbor an arrhythmogenic substrate or a pathological substrate, where the stresses of exercise, such as dehydration, adrenergic surges, electrolyte imbalances, or acid-base disturbances, cause ventricular fibrillation. Indeed, the risk of athletes who harbor these conditions experiencing a cardiovascular event is around 2.5 greater compared to a relatively sedentary individual with the same disease. Here's a bar chart looking at the number of deaths that we see in our population compared to age. So here are the young competitive athletes aged under 35, and here are our middle-aged and older athletes. And you'll see that the vast majority of deaths, in fact, 94% of all deaths in the exercising population, occur in middle-aged and older recreational athletes. And in these individuals, deaths are invariably from atherosclerotic coronary artery disease. This study looks at the risk of acute myocardial infarction during exercise in 1,300 individuals who presented with myocardial infarction during exercise. The overall risk of an acute myocardial infarction is 6 times higher during exercise than at any other time. However, that risk reduces significantly depending on how much exercise one does. So people who exercise intensively on a habitual basis are at a much lower risk. Indeed, the risk of myocardial infarction is 50 times lower in the most active individuals. Here's another study looking at the risk of exercise-related sudden cardiac death from coronary artery disease in 21,000 individuals who were followed up for 12 years, during which there were 23 sudden cardiac deaths. And what this study showed is that the overall risk of sudden cardiac death is around 17 times higher during exertion than at any other time, but this risk is highest in those who are relatively sedentary individuals who have started doing intensive exercise. The risk is much, much lower in ostensibly healthy and habitually trained individuals who exercise on a regular basis. Specifically, the risk of sudden death is 7 times lower in the most active individuals. The mechanisms are multiple, but if we look at an atherosclerotic plaque here, and we superimpose the stresses of exercise, such as metabolic factors, activation of the hemostatic system, shearing forces of the bending and flexing of arteries, high circulating catecholamines, you can see how a plaque could rupture and occlude the coronary artery. There is also the possibility that people may have tight coronary artery stenosis, where there is a supply and demand problem causing myocardial ischemia and promoting ventricular fibrillation. And clearly, we need methods to prevent sudden cardiac death. In young athletes, screening with a health questionnaire and ECG is effective at identifying a large number who have ion channel diseases, accessory pathways, and cardiomyopathies. But such screening is not foolproof, and therefore it's very important that we have personnel and individuals in the general population who can perform CPR and who are comfortable applying an AED. It's important to educate athletes about the risk factors for cardiovascular disease and the risk factors for atherosclerosis. And for people who arrange mass events, it's also important to make allowances for environmental conditions. With global warming, our summers are getting hotter and hotter, and heat stroke is now becoming an important cause of sudden death in endurance exercise. But early CPR is absolutely crucial. Here are 2 population studies looking at exercise-related sudden cardiac death, one from the Netherlands and one from France, where deaths usually occurred in middle-aged men predominantly, and a large number were witnessed. 90% or more were witnessed by the general population. But the success rate was quite different. In France, the success rate of a sudden cardiac arrest was only 45%, whereas in Netherlands it was in France it was 15%, whereas in the Netherlands it was 45%. So what's the difference between the 2 countries? And the difference is down below here. That bystander CPR was performed in 87% in the Netherlands versus 31% in France. The AED was used in 36% of cases in the Netherlands versus only 1% in France. Indeed, early CPR and AED application increases the chance of survival by fourfold. And I'd like to finish finally by discussing very briefly about doping. Uses of androgen receptor modulators, anabolic steroids, erythropoietins, and other hormone and modulators do promote left ventricular hypertrophy and atherosclerotic coronary artery disease, which may cause ventricular fibrillation. But there are very few studies examining the number of athletes that have actually taken these drugs, but these are almost certainly going to be implicated in some of the sudden cardiac deaths that we are witnessing, where an obvious cause is not always identified. So these are my conclusions presented in a figure, looking at the relationship between exercise and cardiovascular events. On the x-axis, we go from sedentary to exercise more than 5 times the current recommendations. And on the y-axis, we look at cardiovascular events. So with increasing exercise, up to 35 met hours, that's up to 5 times the current recommendation, there is a reduction in obesity, hypertension, diabetes, risk factors for coronary artery disease, and there's a reduced risk of atrial fibrillation. People who exercise have an increased coronary reserve in coronary artery disease, they have better functional capacity, and have a better prognosis for heart failure. And as I said, these people benefit if they adhere to the current recommendations, but may continue to benefit up to 5 times the current recommendations. With increasing exercise, there is certainly data that there is a high level of troponin in the bloodstream, which seems to reverse. We know that endurance athletes have a high prevalence of atrial fibrillation, but the fitter they are, the lower their risk of cardiovascular morbidity and mortality. However, there is emerging evidence that people who exercise intensively, a small number, are prone to increased coronary artery calcification, myocardial fibrosis, and right ventricular dysfunction. These may be people that have a genetic vulnerability where environmental stresses such as exercise or even doping could result in adverse remodeling of their coronary arteries and the right ventricle. And then there is a spate, and very rare spate, of very occasional sudden cardiac deaths interspersed along the exercise spectrum, which are usually due to inherited or congenital abnormalities in the young and to atherosclerotic coronary artery disease in the older population. And what we need to do is strive to ensure that the general population exercise for a minimum of 300 minutes per week, at the same time educating our top athletes about the risk factors for cardiovascular disease and sudden cardiac death, and making sure that we've got an efficient system for cardiopulmonary resuscitation and defibrillation in the rare case of an exercise-related sudden cardiac death. Thank you very much for your attention.